and to John. So mine is not a very technical talk, so I do apologise in advance. And I'm really coming at it from a like a clinical perspective and thinking about some of the children we might see in a community setting or public health setting or even in a clinical setting. And often we're faced with children who say, I've got no appetite or I've got too much of an appetite. So it's trying to maybe think about how we take some of the rodent models or bench findings and how we can maybe translate those into either public health messages or information that people could use in a clinical setting. So I just wanted to quickly go back and think about the development of appetite in children. So from a clinical perspective, I've previously worked in neonatal intensive care and paediatric intensive care. So I'm starting right at the very beginning of even in utero appetite development and what might influence all of those factors. So if we think about infants, obviously appetite is mainly homeostatic. So infants are going to respond to those external cues. So they've got signals of gastric distension and they've got blood glucose levels. So when they cry when they're hungry, and they are satiated, and they are exquisitely in tune to their satiety regulators. So they know when they're full and then they stop drinking. So they possess this self-regulation. So it's signaled through these like high intensity cues and then these very subtle behaviors, and they stop sucking and then the feed or meal is finished. And then you have this behavioral transition when children are between 1 and 3 years of age. So then they tend to develop neophobia, where they're frightened of new foods and they restrict or start to reduce the diversity of the number of foods that they eat. And that's completely sort of teleologically normal. So that has been a conserved behaviour that's over, prehistoric times up until now, so that children don't pick up something that's poisonous. So sometimes that's useful survival mechanism, but sometimes that can become in its own right aberrant behaviour. And infants sometimes, or young toddlers, even at this stage, can start to exhibit symptoms of reduced appetite and the seemingly not feeling or demonstrating any hunger. And they tend to be more led by parental regulation of it's time to eat rather than their own self-regulation of I'm hungry, I now must eat. And then in the preschool years, appetite begins to shift from internal cues to external cues. So children are more likely to respond to the sight and smell of food, and they've got parental pressure. So eat another mouthful because you can't be full. So they learn to override their internal satiety cues by parental pressure that they can't possibly be full after a mouthful of food when maybe they are. So they become much more susceptible to eating in the absence of hunger, whereas when they are younger, they're much less likely to do that. And then obviously in middle childhood, that you've got this appetite becomes an executive function, and it's then tied into habits. So children begin to use sort of this physiological and psychological reasoning. They're eating because they're bored or they're stressed, or it's lunchtime rather than physical hunger in itself. So within all of this, you've got genetic predisposition. So there are lots of twin studies that describe that like 75% of satiety variation is inherited. So parents will often describe that they were very fussy eaters or they were difficult eaters as children, and that becomes this intergenerational effect. And then you've got food responsiveness. So there's a genetic predisposition towards that. So you've got excitement at the sight of food. So children become visibly excited, whereas others don't. And then you've got a food avoidance, where you've got this satiety sensitivity and this brain register, where you've got these signal feedbacks from the vagal nerve, which say that you've got obviously abdominal distension, and then you've got this feeling of fullness. And then within that, you've got parental feeding styles. So you've got parents who will override that, who may do responsive feeding, so respond to their children's cues, or may have this pressure to overeat and override children's internal cue. And that then leads to dysregulated eating. And then obviously you've got the whole satiety cascade, which I'm not going to go through, but you've got biological, sensory, cognitive, pre-absorptive, and then this post-absorptive cascade. So you've got this innate perspective, you've got vulnerable perspective, and then you've got socialized. So you can children who are older can delay gratification, children who are younger get easily distracted, and infants stop drinking when they're full. So how does this, if we take two extremes of the spectrum, so I was just going to briefly describe avoidant restrictive food intake disorder, which is an example of disordered eating or eating disorders, and then obesity as both ends of dysregulated feeding. So the implications of ARFID. So ARFID is this relative, well, it's been around for about 10 years. It's has lots of different names. ARFID is the name at the moment, but it's a DSM-5 criteria. So it's a recognised mental health disorder. It's got a around 2.79 per 100,000 children may have be diagnosed with it, but there's a lot of children with ARFID-like symptoms. So there's a lot more children within community settings who may have extreme picky eating or fussy eating that impacts on their social functioning within the family and also external to the family. The mean age is around 11 years, but we see a lot of children who are much younger. And then at the moment, most children in this country are described as being white British ethnicity, but that's probably an underreporting. And then there are lots of comorbidities associated with it, such as anxiety and autistic spectrum disorder. So you will have seen probably this in the press. So this is a picture from a paper that describes Arlo Jack. So he's had appendix surgery. He's lived with ARFID for most of his life. He doesn't eat food. He just drinks milk and all nutrition supplements. So this is a very difficult place to be. And this also then has negative sequelae and impact on his microbiome, and probably then has this circular impact on how he responds to food and his emotional and physiological responses going forward. So often we hear from parents. We have a lot of parents who come in and see us, and you'll have parents describe it's red sauce, right? If I offer my child only eats Heinz ketchup sauce. If I buy Sainsbury's, then they won't eat it, and that seems to be absurd to many people, but this is, they have such narrow ranges of food choices and narrow, they're very brand specific, and you can't change anything. So this, parents describe they're living with heightened sadness, they live with stigma and disapproval, and they find it's a very hard journey. So the GIBA is a really interesting perspective of how we may begin to unlock some of the nuances around this and how we could maybe improve some of the support and treatment that we could offer families of affected children. So there are three main characteristics of ARFID. So there's a low appetite. So whether there are hormonal impacts, fear of aversive consequences, and then there's avoidance based on sensory characteristics. So whether that is then as a result of dysregulated microbiome. So there is very little that's in the literature. There's a little bit on microbial dysbiosis in children with ARFID and disordered eating. And obviously then this leads to, because they don't eat a wide variety of food and they don't eat that much, they may have a loss of bifidobacterium. And the fear of aversive consequences, the dysbiosis can cause GI symptoms in its own right. And then you've obviously got neurotransmitter disruption. So you may end up with a low intake of methyl donor groups. So you've got this lack of folate, choline, betaine, methionine. So you've got this reward, your food is less rewarding, so you don't have that serotonin uptake. And then you've got obviously this bacterioid overgrowth, so you may have this increased abundance compared to healthy peers, and this may then also impact on your gut-brain signaling pathways. So if we then look at the other side of the coin, obesity, so as we all know, the number of children with excess weight in the UK is increasing. So children who are 4 to 5 years of age, you've got probably around 22% are overweight or obese, and then that increases to around 34% for 10 to 11-year-olds. So again, children have described from a qualitative perspective, for dinner, they always want more food than necessary because they still feel hungry. So there's a lack of satiation. They know eating isn't healthy, but they still want to carry on eating. There's obviously emotional distress that even when they've tried really hard to reduce their weight or stay at the same weight, they continue to gain weight. So it causes a lot of emotional distress in young people. So again, this is probably better described. There is a microbial dysbiosis in children. So there's pro-hunger and pro-storage. So there's an energy harvesting hypothesis where complex carbohydrates, they become super salvagers and absorb more calories from the food that has been eaten. And then there's this systemic endotoxemia as a result of a leaky gut. So LPS causing this ongoing inflammatory cascade causing the brain and hyperleptinemia. And so there's a failure of feedback mechanism to signal satiety. And there may be satiety blunting. So there's a lack of diversity as a result of, again, limited diversity of food, so maybe poorer intake of fruit and vegetables. So this then impacts on your short-chain fatty acids. And there's a couple of really nice papers about all of this and the use of probiotics, prebiotics, symbiotics. But again, I think all of this is that magic bullet. It becomes oversimplified, and it's not. The results of probiotic studies certainly don't suggest that is has long-term impact. So I think just to wrap up, so the clinical and public health challenges are: how do we translate GIBA insights into clinical or public health practice? The use of probiotic supplementation is probably too simplistic. And how do we increase food diversity that is impacted by neophobia and other psychological, I can't think of the word, challenges. So public health initiatives around healthy eating and food are very challenging, and they're impacted by food justice. So obviously free school meals. There's intergenerational eating habits which impact on the ability to expand diversity and try new foods. Obviously town planning and access to good food. And then the UK Food Council is trying to, obviously there's a high level of food insecurity and food distribution in the UK at the moment. So that is all from me, and